So minimal residual disease has become a quite important endpoint in patients who are achieving complete remission. Patients with CR, we know, has substantial amount of disease, and there is a wide variation in how much disease is left. So a number of investigators, including ourselves, have studied CR patients and see how many of them have MRD. Now, MRD has a different depth of measurements. There are older methods with 1 cell in 10 to power 4 cells. There are newer methods with 1 cell in 10 to power 6 cells. But with either of those depth, 4, 5, or 6, most of the studies have shown that those patients, even in CR, when they are MRD negative, they do better than those who are not. So we had a meta-analysis of a large number of patients, over 2,000 patients. And then we focused on subgroup of patients who achieved complete remission, and then divided them into those who had MRD negative CR and those who had MRD positive CR. And the important finding is that even within all the patients with CR, if they achieve MRD negativity, they have significantly superior progression-free survival and significantly superior overall survival. So this was a large meta-analysis. We had 14 large studies included in it. 5 of them have CR and other results in it. And it clearly confirmed that getting MRD negativity in CR patient is important. So then there are more newer studies. So we have a very good collaborative work with our French group, IFM group, and Professor Loiseau presented this data in which patients in the IFM-DFCI study who got CR and then looked at whether they are MRD negative or positive. And that study also clearly showed that patients who are MRD negative do better. But there are a few other important findings from that study which is important in how we treat patients in future. So that study showed that if we are able to detect 1 cell in a million, 10 to power 6, that's the best depth that we can achieve and will give the best result. If we have 10 to minus 5, so 1 cell in 10 to 1 cell in 100,000 or 1 cell in 10,000, that's still also good, better than having MRD positivity, but it's not as good as 10 to minus 6. So our standard is becoming ability to detect 1 cell in a million cell. That's a very important endpoint. Getting that depth, that study showed that if you get to MRD negativity, doesn't matter what treatment you use, you do equally well. And the importance is that patients who got, say, transplant and got MRD negative, another patient who did not get transplant and got MRD negative, that patient may not need transplant. They do equally well. So this is very important future path for us, that getting to MRD negativity is important, not what treatment we use. And the second point that is not black and white yet from that study, because we need still more patients, but it also shows that patients who are high-risk myeloma, if they get MRD negativity, they do equally well. And there were presentation here, 2 of them, which confirms a similar point, that even a high-risk patient, if they get MRD negativity, they do better. There's also studies in relapse patients, where relapse patients, if they get MRD negativity, they do better. So I think there is good bit of accumulating data from all various studies that suggests that we should get to MRD negativity. So then the question comes, can we use it in our regular practice? And we are actually beginning to do that in our center at Dana-Farber, we do measure now MRD negativity in patients for clinical practice. How we apply it to patient is still not black and white. So if somebody gets MRD negativity, would I not do transplant? That's not yet black and white. We need a little more studies, and we actually have planned studies to answer exactly those questions. But if a patient decides that I'm MRD negativity, I don't want transplant, I will be a little bit more comfortable in saying that's okay, we can do it later if you relapse. So I think it's already beginning to affect our management of the patient. Can we do maintenance forever, which is what we do right now? But if he's MRD negativity, do we need to do it? Maybe not. Again, studies are ongoing to answer that question, but there is already questions in everybody's mind that maybe if we are MRD negative, then we don't need an indefinite maintenance. We can do shorter maintenance. And so these are the practical applications which are almost there. We will have more results in the next 1 to 2 years, but we are beginning to use this in some meaningful way in selected patients. I wouldn't make a global statement yet, but in a selected patient, we can look at MRD negativity, even with CR, and then decide what do we do with the patients, keeping in mind toxicities and side effects and inconvenience and cost. We can put this together in doing it.